Okay, let's unpack this. Picture this. You're on the floor, a patient needs their medication, and the order is in one unit of measurement, but the medication on hand is in another.
Hmm.
That split second where you need to calculate accurately, that's really our focus today.
Right.
This deep dive into medication and intravenous dosage calculations, it's all from Chapter 15 of Saunders' Comprehensive Review for the NCLEX-PN examinations, 7th edition. It's going to hopefully equip you with the knowledge to navigate those critical moments with, well, more confidence.
What's fascinating here, I think, is how seemingly straightforward calculations are truly like a cornerstone of safe patient care. Accuracy isn't just a nice to have, it's fundamental. It prevents harm.
Absolutely. So our mission with this deep dive is really to extract the vital knowledge within this chapter, giving you a clear understanding of these medication and IV dosage calculations. Think of this as maybe your guided tour through the essential principles.
Helping you get a real grasp of why these calculations matter so much.
Yeah, exactly. And if we connect this to the bigger picture, I mean, remember, this isn't just about mastering formulas for an exam, is it?
Not at all. It's about building those critical thinking skills you'll use every single day as a nurse. Making sure your patients get the right medication, the right dose, every single time.
Spot on. We're going to highlight the core ideas here. Clinical judgment and safety. So where do we even begin? Let's start right at the beginning. Those essential steps you take before giving any medication.
That raises a crucial point, right? Before we even think about a calculator, what are those non-negotiable actions, the things a nurse must do for medication safety?
Well, box 15-1 in the chapter lays it all out pretty clearly. It starts with a thorough check of the medication prescription itself. Is it complete? Is it clear? Is it accurate? Then there's medication reconciliation, which is, so vital because it's our chance to catch any discrepancies. Differences between what a patient should be taking and what they are actually taking.
Huge potential for errors there if you miss that step.
Totally.
Okay.
And we also absolutely have to know about any allergy history. That's a non-negotiable safety point, obviously.
And it goes beyond just the paperwork, doesn't it? It's about really knowing your patient in that specific moment.
Precisely. You need to assess the client's current condition and really understand why they're getting this particular medication or IV fluid.
Okay.
It's also essential to understand their level of knowledge about it. Do they need any teaching? Especially if they'll be managing meds at home later.
Right, that patient education piece.
Yeah, and let's not forget those sociocultural or even religious beliefs that might influence how a patient feels about their treatment.
What stands out to you as particularly important in this initial phase? Anything jump out?
For me, it's just the sheer number of layers involved. It really emphasizes that giving medication isn't just, a task. It's a whole process with multiple critical checkpoints. And even before we think about the dose, we have to ask, are the units in the prescription the same as what's on the medication label? Do we need to do any conversions?
Which leads us directly to the 7 rights of medication administration, those like guiding principles for safe practice. What are they again?
Okay, the 7 rights. Right medication, right dose, right client, right route, right time and frequency, right indication, and right documentation. They're absolutely fundamental for preventing med errors.
And these aren't just words on a list, are they? Each right is a practical safeguard. Think about the right client. In busy settings, especially during shift changes maybe, verifying at least 2 patient identifiers becomes such a critical step. Avoids those dangerous mix-ups.
Exactly. And it doesn't start with just the rights. Box 15-1 also reminds us to check vital signs, review relevant lab results, and be alert for any potential interactions with food or other meds before we administer anything, assuming it's clinically appropriate, of course. This ongoing assessment is key.
So even as you're literally about to give the medication, you're still assessing and verifying.
Absolutely. And the final piece of this initial stage, thorough documentation. You've got to record that the medication was given time, dose, route, your initials, and then, importantly, document the client's response to it.
Okay, so we've established the critical how of approaching med admin. Now let's dive into what the different systems we actually use to measure these medications.
Right. Chapter 15 starts by outlining the drug measurement systems. The metric system is, well, the most prevalent in healthcare and definitely the primary focus for the NCLEX.
What are the essential things to remember about the metric system, as described in box 15-2? Why is it so widely used in medicine?
Okay, so the core units are meter for length, liter for volume, and gram for mass. Then we have the common abbreviations you see everywhere, ml, mlkg, gmg, and mcg. What makes the metric system so advantageous in healthcare, and really why it reduces error potential, is its decimal base.
Could you elaborate on that a bit? How does that help?
Sure. Because it's based on powers of 10, converting between units is really straightforward. It's just a matter of multiplying or dividing by 10 or 100 or usually 1,000. Or, as box 15-3 shows, you can simply move the decimal point.
Okay.
3 places to the right to go from a larger unit to a smaller one, like grams to milligrams, and 3 places to the left for smaller to larger, like milliliters to liters. So, a gram is always 1,000 milligrams, and 250 milliliters is always 0.25 liters. Simple.
That consistent decimal relationship really does simplify things, especially compared to systems with more sort of arbitrary conversions.
Exactly. Which brings us to the other systems mentioned, apothecary and household. The book notes that apothecary measures like dram, grains, minim aren't used as commonly these days.
However, it's still important to have some awareness, wouldn't you say? You might still encounter these terms, maybe in older medical records or certain prescribing habits.
Right, good point. And then we have the household system. Drop, teaspoon, tablespoon, ounce, pint, cup. Now, this is a key point for anyone prepping for the NCLEX. You will not be required to do direct conversions between the apothecary and metric systems on the exam.
Okay, it's good.
But as the book points out, you might still see apothecary terms used in some clinical settings, so be aware.
So, while not actively tested for conversion, recognizing the terms is still clinically relevant.
Got it. Now, what about some other common drug measures we need to understand?
Okay, we have the milliequivalent, often abbreviated MEQ. Box 15-2 defines it as a way to express the amount of a medication in grams that's dissolved in 1 LPL of solution. A common example is potassium. It's frequently ordered and measured in EBQ, like say 20 milliQ of potassium chloride.
So it's essentially a measure of the electrolyte concentration or the ionic activity of a medication in solution rather than just weight. Precisely. Then there's the unit. What's interesting about units is that they don't measure the physical weight of a medication, but rather its strength or its biological activity.
Oh, okay.
Penicillin, heparin, insulin, those are classic examples of meds measured in units.
That makes sense, especially for biological products where maybe the purity and potency could vary slightly from batch to batch based on weight alone.
Okay, now that we understand the different measuring systems, what happens when a doctor's order uses one system but the medication label uses another? Big potential issue.
That's where the crucial skill of conversions comes right into play. As box 15-3 showed us, within the metric system, it's all about those powers of 10. Pretty easy.
Right.
But converting between household and metric systems is a bit different. The book emphasizes, and this is important, that these are equivalent measures, not exact equals.
That's a subtle but really important distinction for safety, isn't it? Why is it so vital to understand their equivalence, not precise mathematical equalities? Because, well, while we might say 5 millinel is equivalent to 1 teaspoon for medication purposes, a real household teaspoon can actually vary quite a bit in volume.
I see.
This is why using standardized measuring devices like oral syringes or calibrated cups is so important for accuracy, especially with liquid meds. The chapter stresses that conversion becomes necessary when the prescription and the available medication are measured in different systems.
And what's the primary method the chapter presents for performing these necessary conversions? How do we do it reliably?
The book introduces the method of ratio and proportion as a fundamental tool. Boxes 15-4 and 15-5 walk us through exactly how to set this up.
Okay.
So a ratio compares 2 quantities, like 1 part med to 2 part solution. A proportion then states that 2 ratios are equal, and we use this equality to find an unknown quantity. The formula they provide is H, what's on hand, AV, the vehicle or form it's in, AD, the desired dose, the X, the unknown amount to give.
Let's break that down just for clarity. H on hand is the strength or quantity of medication you have available. V vehicle is the form it's in, like tablets, or the volume of a liquid. Example, 50 milligrams per 1 tablet, or 100 milligrams per 5 milliliter. D, desired dose, is what the prescription orders, and X is the unknown quantity you need to calculate how many tablets, how many ml.
Exactly. To solve for X, you multiply the 2 inner terms, the means, and the 2 outer terms, the extremes. These products are then equal, and you just solve the resulting equation for X. Box 15-4 gives a basic math example to illustrate the principle itself.
And box 15-5 applies this directly to a medication conversion scenario, using nitroglycerin as an example. The order is for grain 1150, and the tablets available are labeled 0.4 milligrams.
Right.
So knowing the equivalence that 1 grain equals about 60 milligrams, they set up the proportion. 1 grain, 60 milligrams, 1150 grain, X milligram. Solving for X reveals that 1150 grain is equivalent to 0.4 milligrams.
Meaning 1 tablet is the correct dose in that case. It's a systematic approach, helps minimize errors when you're converting between these different systems. Okay, so once you've figured out the correct dose and you have the medication right there in front of you, what's the next critical step?
Paying very close attention to the medication label itself. What key pieces of information must a nurse locate and verify on every single medication label every time?
Okay, a medication label will always include both the generic name and often a brand or trade name. And for those preparing for the NCLEX, it's really important to know that the exam primarily uses generic names.
Good tip.
So focusing on learning those generic names during your studies is, well, a smart strategy. Of course, in clinical practice, you'll definitely see both.
So be prepared for both scenarios. What's another piece of absolutely vital information you must check on that label before giving any medication? Non-negotiable.
The expiration date. Always, always double check that the medication hasn't expired. Using expired meds can be ineffective or, even harmful. Following the label check, the next crucial piece of information comes from the medication prescription itself.
Yeah. What are the essential components that must be present in a complete and valid medication prescription as outlined there in box 15-6?
A valid prescription needs to have the client's full name, the date and time it was written, the complete name of the medication, the exact dosage prescribed, the route of administration, like oral, 4 IM, the frequency, how often to give it, and of course, the signature of the licensed healthcare provider who prescribed it.
Okay.
The specific times of administration, if they aren't detailed, are usually determined by the healthcare agency's own policies and standard schedules.
And the importance of using standardized, accepted abbreviations in prescriptions can't be emphasized enough, can it? To avoid confusion.
Absolutely. To prevent misunderstandings and potential errors, prescribers should only use abbreviations, acronyms, symbols that are approved by the Joint Commission, and also align with the specific guidelines of their healthcare agency. There are do not use lists for a reason. And if, as a nurse, you ever encounter any part of a prescription that is unclear, illegible, or raises any questions at all, it is your professional responsibility to immediately contact the prescriber for clarification. Never assume or guess.
That direct verification is such a critical safety mechanism. Okay, now let's move on to discuss the different forms that medications can take, starting with those given orally.
Oral medications are probably the most familiar form for most people. The chapter discusses scored tablets. Those are the ones with a line or indentation across them. It makes it easier to break them accurately for partial doses.
And they recommend using a pill cutter for that, right? Why is that better than just trying to snap it by hand?
Yeah, it helps ensure a more even and accurate division of the tablet. You get a much more precise partial dose compared to an uneven break you might get by hand.
Makes sense.
Then we have enteric-coated tablets and sustained release capsules. These are specially formulated. They release the medication slowly over time, usually by delaying absorption until the med reaches the small intestine. And the key instruction for these is do not crush, chew, or break them. If you do that, you destroy the intended sustained release mechanism, and you could cause a rapid, potentially harmful release of the entire dose all at once.
Right, big danger there. And what about regular capsules? What are they made of?
Capsules usually have an outer shell, typically made of gelatin, that encloses the medication. That medication inside can be in powder, granular, or even liquid form.
Okay.
The chapter also covers oral liquids. These are solutions where the medication is already dissolved in a liquid base. The label will clearly state the concentration, the amount of medication in a specific volume of liquid, like milligram per ml.
And how are these liquid medications typically measured for administration? What tools do we use?
Usually with a medicine cup. Standard medicine cups have a capacity of 30 milliliters, which is about 1 ounce, and they're marked with calibrations for measuring teaspoons, tablespoons, and ounces. To ensure an accurate measurement, the cup should be placed on a level surface, and you should read the liquid level right at eye level, aligning the bottom of the meniscus with the correct marking.
Okay, good technique reminder.
Now, for smaller volumes, specifically less than 5 millimels, the book really emphasizes using an oral syringe for greater accuracy. Those cups aren't great for tiny amounts.
Right, too much room for error.
Exactly. And for administering liquid meds to children, calibrated droppers are often used to measure those very small, precise doses.
The chapter also presents that what should you do? Critical thinking scenario on page 180 about preparing 30 millimeters of liquid medication. What are the key takeaways from the recommended actions there?
Yeah, that scenario reinforces several important points. Like we said, always use a medicine cup on a flat surface, read at eye level, maybe use your thumbnail to mark the line. It's crucial not to mix different liquid meds or mix liquids with solids like tablets in the same cup. Any medication poured but not used should never be returned to the original bottle. You have to discard it properly. When pouring, hold the bottle so the liquid flows away from the label, preventing spills from making it unreadable.
Practical tip.
Yeah. And for meds that can irritate the stomach, sometimes dilution is needed, or they should be given with meals. And offering ice chips beforehand can sometimes help minimize unpleasant tastes for the patient.
Really practical advice there for safe and comfortable oral medication administration. Okay, now let's transition to parenteral medications, those administered by injection.
Right. Parenteral administration always means giving a medication by injection. This includes intravenous, 5E, intramuscular IM, intradermal, and subcutaneous routes. Figure 15:1 in the chapter actually shows the typical angles of insertion for each of those injection types.
Okay, and how are these typically packaged?
They come in various ways. You've got single-use glass ampules, single-dose or multi-dose vials with rubber stoppers, and also pre-filled syringes or cartridges.
What are the general recommended maximum volumes for intramuscular and subcutaneous injections at a single site? Are there limits?
Yes, definitely limits. For intramuscular IM injections, the general guideline is not to exceed 3 milliliter per injection site. And for the deltoid muscle specifically, it's usually limited to 2 milliliter because it's a smaller muscle.
Okay.
For subcutaneous injections, the maximum volume is typically 1 milliliter per site. If a prescribed dose requires a larger volume than these limits, it's essential to question the order and potentially divide the dose into multiple injections at different sites.
Good point.
And it's also really important to remember these are general adult guidelines. Pediatric patients have different maximum volume recommendations based on their age and muscle mass, which are discussed elsewhere in the book in the PEDS sections.
Right, always consider the patient population. And the primary tool for accurately measuring these injectable medications is the syringe. What are the key types of syringes discussed in this chapter?
The standard 3 milliliter syringe is a very common one. It's calibrated in tenths of a milliliter, 0.1 milliliter. When you're filling a syringe, it's crucial, really crucial, to align the top ring of the plunger, the ring closest to the needle hub, precisely with the desired calibration marking on the syringe barrel. Figure 15:2 illustrates this well.
Okay, the top ring, not the bottom or the pointy part.
Exactly, the top ring. And it's always a good safety practice to question any prescribed injection volume that seems unusually large or, conversely, unusually small for that specific medication and the patient. Use your clinical judgment.
What about those pre-filled medication cartridges that are often used? How do they work?
Yeah, those are convenient. They're single-dose units where the medication is already measured in a cartridge. This cartridge then fits into a reusable holder that has a plunger mechanism. Some are even designed with a bit of extra space in case a second medication needs to be added, though you need specific orders for that. Because they're pre-filled for a single dose, any excess medication left in the cartridge must be discarded after use, following your agency's specific policies on waste.
Right. Don't save leftovers.
No. And it's also vital to carefully read the manufacturer's instructions for each type of pre-filled syringe. Some might require you to expel any air before administering the medication, others might not. You have to check.
And what are the general guidelines for rounding injectable medication doses for adult patients? How precise do we need to be?
Generally, for standard adult injectable medications, the final calculated dose is rounded to the nearest tenth, 0.1 of a milliliter, and you'd measure that using the milliliter scale on the syringe, typically a 3 milliliter one.
Okay, nearest tenth.
For instance, if your calculation comes out to, say, 1.28 milliliter, it would typically be rounded up to 1.3 milliliter. However, and this is key, it's absolutely essential to always adhere to the specific rounding policies and procedures of your healthcare agency, as these can vary. Don't just assume.
Always follow local policy.
Yep.
Got it. The chapter also mentions a 5 milliliter syringe. When is this type of syringe typically used in practice?
A 5 milliliter syringe, which is calibrated in fifths of a milliliter, so 0.2 milliliter increments, might be used when the calculated or prescribed volume is greater than 3 milliliter but doesn't really require a much larger syringe. Figure 15:3 shows one.
Okay.
There are also larger syringes available, like 10 milliliter, 20 milliliter, even 50 milliliter syringes, but those are more commonly used for things like diluting medications or for irrigation purposes, rather than for direct administration of a large volume of undiluted medication as a single shot.
Right. Now, for situations requiring very precise measurements of small volumes, we have specialized syringes. Let's discuss the tuberculin syringe first.
Okay, the tuberculin syringe, shown in figure 15-4, has a very small total capacity, only 1 milliliter. It's specifically designed for measuring and administering very small or critical amounts of medication.
Like what kinds of meds?
Things like the PPD for tuberculosis testing, allergen extracts for allergy testing, various vaccines, and certain pediatric medications where the doses are often tiny.
Oh, okay.
The tuberculin syringe is calibrated in hundredths of a milliliter, 0.01 LOL, with markings also indicating every tenth of a milliliter, 0.1 LOL. This really fine calibration allows for highly accurate measurement of those small, critical doses.
And then we have the very specialized insulin syringe. What's absolutely crucial to understand about these?
Yes, the standard U100 insulin syringe, which is depicted in figure 15-5, is designed and calibrated exclusively for measuring U100 strength insulin. That's the most common strength.
Only for U100 insulin.
Only. It has a total capacity of 100 units, which happens to be equivalent to 1 milliliter, but it's marked in units, not ml. For patients needing smaller doses, there are also low-dose insulin syringes available, like the half ml, which holds 50 units, and the 310 milliliter, which holds 30 units sizes.
Okay.
The most critical point, the one thing to really hammer home, is never, ever try to measure insulin in any other type of syringe, like a tuberculin or a standard 3 millirel syringe. Using the wrong syringe would lead to a significant and potentially very dangerous overdose or underdose.
A huge safety issue. What about the procedure for combining different types of insulin, like regular and NPH, in the same syringe? Is that allowed?
Yes, if a patient's prescription calls for both regular, which is short-acting and clear, and NPH, which is intermediate-acting and cloudy insulin to be given at the same time, they often can be drawn up and mixed in the same U100 syringe.
Okay, how do you do that correctly?
There's a common mnemonic to help remember the correct order for drawing them up. RN, think registered nurse. You drop the clear regular insulin first, then you drop the cloudy NPH insulin second.
R then N. Why that order?
This order prevents contaminating the vial of the clear, short-acting, regular insulin with the longer-acting, cloudy NTH insulin. Keeps the vials pure.
Makes sense. And insulin pens seem increasingly common, especially for patients managing their diabetes at home. How do those work?
Yeah, insulin pens are pre-filled devices. They use disposable, very fine needles. Typically, the pen needs to be primed. You dial up a small amount, usually 2 units, and push the button to get a dropout before the first use, and often with each new needle change. This ensures accurate dosing and removes any air bubbles.
Okay.
Each pen is strictly for single patient use, never shared. The patient, or the healthcare provider, dials in the prescribed dose using a dial on the pen, inserts the needle, and then pushes a button to inject the insulin. Their ease of use and portability definitely make them a popular choice for many people outside of the hospital.
Right. Finally, in our discussion of ingestion equipment, the chapter highlights the importance of safety needles. What are those designed to do?
Safety needles are designed with a built-in shielding mechanism. After you give the injection, you can activate this shield. Sometimes it's a sheath that slides over, sometimes the needle retracts. This shield covers the sharp needle point.
And the purpose?
It significantly reduces the risk of accidental needle stick injuries to healthcare providers, housekeepers, anyone who might handle the sharps container. A crucial safety feature.
Definitely protects healthcare workers. Okay, now let's move on to discuss medications that aren't supplied in liquid form, but instead come as a powder. Why is that?
Some medications are just unstable in liquid solution for extended periods. They degrade. So they're manufactured and packaged as a powder in a vial to maintain their potency.
Okay.
Before these medications can be administered parenterally, they need to be dissolved in a sterile liquid diluent. Usually it's sterile water for injection or sterile normal saline, but you must follow the specific instructions provided by the manufacturer. This process of dissolving the powder is called reconstitution, as outlined in box 15-7.
What are the most critical considerations when you're preparing to reconstitute a powdered medication? What do you absolutely need to check?
The absolute most important thing is to carefully read and follow the directions that come with that specific medication, either right on the vial label or in the package insert. Don't guess or assume it's the same as another drug.
Right. What will those instructions tell you?
They'll specify the exact type and amount of diluent to use. They'll also indicate what the final concentration or strength of the reconstituted medication will be, like how many milligrams per milliliter, and often the total volume of the solution after reconstitution.
Okay.
It's important to note that the powdered medication itself often adds to the overall volume of the solution. So the final volume will likely be greater than the amount of diluent you initially added. The label tells you this final concentration.
Ah, good point. The powder takes up space. And what are the specific labeling requirements for multi-dose vials that have been reconstituted if you're not using it all at once?
If you're reconstituting a medication in a multi-dose vial, meaning you might draw more than one dose from it over time, you absolutely must label the vial clearly. You need the date and time of preparation, your initials as the person who prepared it, and the date and time by which the medication will expire after reconstitution, which might be hours or days later, depending on the drug.
Okay, clear labeling.
And critically, you also need to clearly indicate the strength of the medication per unit volume, right there on the label, for example. Right? 100 milligram per ml or whatever the concentration is. This ensures that anyone using the vial later knows exactly what they're drawing up.
Proper and thorough labeling is absolutely essential for preventing potentially dangerous medication errors down the line. Okay, now that we've covered the different forms of medications and how to prepare them, let's get into the core of our discussion. Calculating the correct dosage, as detailed back in box 15-8.
Right. This is where everything we've discussed so far really comes together. When you're calculating dosages for oral medications, always double-check your calculations. As a general guideline, if your calculated dose requires you to give more than, say, 3 tablets for a single administration, it's a really good practice to pause and question the prescription. It might be an error.
That reasonableness check.
Exactly. Similarly, for parenteral medications, be very cautious and question any prescribed dose that seems unusually high for that particular medication and the patient's condition or weight. Does this make sense?
The chapter also emphasizes the critical importance of ensuring unit consistency throughout your dosage calculations. Why is this so vital?
It's essential because you just can't accurately perform a calculation if you're mixing different units of measurement within the same formula. You have to make sure that all the quantities in your equation are in the same system, like all metric or all household, though metric is preferred. And within that system, that the units are the same size. For example, all milligrams or all grams or all ml.
So convert first if needed.
Yes. This often means you'll need to perform a unit conversion before you can proceed with the dosage calculation itself, and always take that moment to think. Does the calculated amount to be administered seem reasonable for this drug, this route, this patient?
We've already touched on rounding rules for adult injections. What are the specific guidelines for rounding doses that are very small, considered critical, or intended for children? Is it different?
Yes, it can be. For standard adult IM or subcutaneous injections, like we said, the dose is generally rounded to the nearest 10th, 0.1 LOL. When using a standard 3 milliliter syringe, always follow agency policy.
Yeah.
However, when dealing with very small doses or critical medications where precision is absolutely paramount, like heparin maybe, or when calculating doses for pediatric patients, the calculated volume is typically rounded to the nearest 100th. 0.01 LRL.
And what syringe would you use for that?
You'd need to measure that using a 1 ml tuberculin syringe because it has those 100th markings. Again, always refer to your specific agency's guidelines, as they might have even more specific rounding rules for certain situations or drugs.
What are the primary methods or formulas that the chapter introduces for actually performing these dosage calculations? What tools do we use?
The chapter highlights the standard formula, which you see a lot. It's desired dose, what the prescription orders, divided by the available dose, what's stated on the medication label like milligram per tablet or milligram per ml, multiplied by the quantity, the form in which the medication is available, like 1 tablet or 1 ml or 5 ml.
So D over A times Q.
Exactly. DAXQ. For example, if you need to give 100 milligrams of medication and you have tablets that are 50 milligrams each, the calculation would be 100 milligram desired 50 milligrams available by 1 tablet equals 2 tablets.
Pretty straightforward.
Yeah. The book also briefly mentions dimensional analysis as another valuable method for dosage calculation. That involves setting up an equation where you strategically arrange conversion factors so that units cancel out, leaving you with the desired unit in the final answer. Some people find that method very intuitive and safer.
2 good methods to know. And the final but perhaps most significant point in this section addresses the nurse's accountability. What does it say?
Yes. It's absolutely crucial to understand that as the nurse administering the medication, you are legally responsible for ensuring that the dose is correct, period.
Regardless of where the error came from.
Exactly. This holds true regardless of where a potential error might have originated, whether it was a mistake in the original prescription, an error on the medication label itself, or maybe a flaw in your own calculation. This responsibility just underscores the absolute necessity for meticulous accuracy, careful double-checking of all calculations, maybe even having another nurse check critical ones, and always questioning anything that seems off or doesn't feel right.
That's a heavy responsibility, but essential for patient safety. Now let's briefly touch upon percentage and ratio solutions, as these can sometimes be encountered in medication orders and require careful interpretation. How are they defined?
Okay, percentage solutions, as explained in Section XA, express the concentration of a medication as the number of grams of the solute, the medication, contained in 100 milliliters of the total solution.
Okay, grams per 100 milliliter.
Right. For instance, a 10% calcium gluconate solution means there are 10 grams of pure calcium gluconate dissolved in every 100 milliliters of the solution.
Got it. And ratio solutions.
Ratio solutions, discussed in Section XB, express the concentration as the number of grams of medication present in the total number of milliliters of solution indicated by the ratio. The classic example is epinephrine 1.1000 solution.
What does that mean?
It means there is 1 gram of pure epinephrine dissolved in a total volume of 1,000 milliliters of the solution.
Understanding these expressions of concentration is vital for accurately calculating the amount of medication being administered, especially with maybe intravenous fluids or certain injectable medications. Okay, finally, let's move on to the important topic of intravenous flow rates as outlined in Box 15 and 9. What's the first key point?
Once an IV infusion is started, continuous and frequent monitoring of the flow rate is absolutely essential. Even if an electronic infusion device, a pump, is being used, pumps can malfunction or lines can get kinked.
Right, don't just set it and forget it.
Definitely not. You need to check the rate regularly, visually confirm it's dripping if it's a gravity feed, check the pump settings, and assess the IV site, all following the specific policies of your healthcare agency.
What if an IV infusion is running behind schedule? Can you just speed it up to catch up?
No. That's the critical rule. Never attempt to just arbitrarily increase the flow rate to catch up if an IV is behind. Doing so can rapidly overload the patient's circulatory system, leading to serious complications like fluid overload or pulmonary edema.
So what should you do?
You must collaborate with the primary healthcare provider, PHCP. Discuss the situation, determine if a rate adjustment is appropriate, and carefully consider if the patient's condition, especially if they have cardiac, pulmonary, renal, or neurological issues, can actually tolerate an increased rate safely. Sometimes the answer is just to document it and continue at the prescribed rate.
And if a decision is made to carefully increase the flow rate after consultation, what are some important signs and symptoms the nurse should monitor the patient closely for?
You need to be super vigilant for any signs and symptoms of fluid overload. This could include an increase in heart rate, an increase in respiratory rate, the development of crackles or other adventitious breath sounds indicating lung congestion, maybe new shortness of breath, or any signs of edema, like swelling in the legs or even jugular venous distension, JVD.
Okay, lots to watch for. How are IV fluids typically prescribed?
Intravenous fluids are most commonly prescribed in terms of milliliters per hour, mLHR. That's the standard unit for infusion pumps.
But what if you're manually regulating an IV infusion, using the roller clamp on the tubing?
Right. If you're regulating by gravity using a drip chamber, you need to calculate the flow rate in drops per minute, GTT Teasman. That's how you count the drops falling in the chamber to set the rate.
This brings us to the intravenous tubing itself. Does the tubing type matter for the flow rate?
Absolutely. IV tubing is calibrated based on the size of the drops it delivers, and this is measured in drops per milliliter, GTT-SML. This drop factor is always printed clearly on the packaging of the IV tubing. You have to know the drop factor of the tubing you're using.
What are the common types?
Standard IV tubing, also known as macro drip sets, typically deliver larger drops. They usually deliver either 10 or 15 GTAs per ml, depending on the specific manufacturer. These are generally used for routine adult IV infusions where you don't need extreme precision.
Okay, macro drip is 10 or 15. What about smaller drops?
Then you have mini drip or micro drip tubing sets. These deliver a much smaller drop size. They always deliver 60 GTAs per ml. Because they deliver a larger number of much smaller drops, they allow for very precise flow rates.
Where would you typically use micro drip tubing?
They're used when very precise fluid administration is critical, such as intensive care units, ICUs, for pediatric patients, or when infusing potent medications that require very accurate titration.
Makes sense. The chapter provides essential formulas for calculating these IV flow rates. Could you review those for us? How do we figure out mLHR or GT Teasman?
Absolutely. To calculate the hourly rate in MLHR when you know the total volume to be infused and the total infusion time in hours, the formula is pretty simple. Total volume in ml divided by total hours equals MLHR.
Okay, volume time rate.
Exactly. Now, to calculate the flow rate in drops per minute, GTT/Schiesmann, for manual regulation, the formula is total volume in ml multiplied by the drop factor of the tubing in GTT/SML divided by the total infusion time in minutes. So, volume x drop factor, time in minutes equals GTT/Schiesmann.
Got it. Need time in minutes for that one.
Right. And finally, if you need to figure out the total infusion time in hours when you know the total volume and the infusion rate in ml per hour, the formula is total volume in ml divided by the rate in ml per hour total hours.
So these are really the fundamental calculations nurses need to be proficient in to safely administer intravenous fluids, whether by pump or gravity. Now, the chapter wraps up with a valuable set of practice questions, doesn't it?
Yes, questions 116 through 130. They provide an excellent opportunity to actually apply all the knowledge we've just been discussing. Each question presents a clinical scenario. Here's the medication order, here's the label info, and challenges you to calculate the correct dosage or flow rate.
And while we won't go through each question individual right now, it's incredibly beneficial for you, the listener, to work through these practice problems on your own. The chapter provides detailed rationales for each answer, which is super helpful.
Yeah, the rationales explain the steps involved in the calculation. They usually show the formula used and often include helpful test-taking strategies and even mention the level of cognitive ability being tested by that specific question, like analysis or application.
For example, looking at them, question 116 asks you to calculate the volume to administer of hydromorphone hydrochloride, given the prescribed dose and the concentration available in the vial. Requires a basic DA/XQ calculation.
Right. Question 117 involves calculating the number of tablets for an oral digoxin order again. Pretty straightforward. But then several questions, like number 128, focus specifically on calculating the correct IV flow rate in drops per minute, using that formula we just discussed.
And as you work through these, pay close attention to any questions that require you to perform unit conversions before you can even start the main calculation. Like question 123 involves converting grams to milligrams before you can figure out the number of tablets. A common extra step.
Exactly. And some questions, like number 126, which involves a temperature conversion from Fahrenheit to Celsius, highlight the importance of considering additional clinical data when making medication administration decisions, even if it's not directly part of the dose calc itself. It's about the whole picture.
These practice questions truly reinforce the practical application of all the concepts covered in the chapter, don't they? From basic dosage calculations to more complex 4E flow rate problems, working with different units, different medication forms. It's all there.
They really do. And by diligently reviewing the rationales provided after you try them, you can gain a deeper understanding of the underlying principles and really strengthen your problem-solving skills in this critical area of nursing practice. It's a really valuable resource for solidifying your knowledge and, of course, preparing for the NCLEX.
Absolutely. So, to maybe summarize this comprehensive deep dive into Chapter 15, where have we been?
Okay, so we've thoroughly explored, I think, all the essential aspects of calculating medication and intravenous dosages from this chapter. We started way back with the critical steps before medication administration. The checks, the reconciliation, the rights. Then we covered the different drug measurement systems metric primarily, but also touching on apothecary and household along with those other measures like mill equivalents and units.
Right. Then we dove into the crucial skill of conversions, both within the metric system, which is fairly easy, and between household and metric units using ratio and proportion.
Yep. We examined the key information you must find on medication labels and the necessary components of a complete medication prescription. Lots of safety checks there.
We also discussed the administration of oral medications in their various forms, tablets, capsules, liquids, and the proper use of measuring devices like cups and oral syringes.
Then we moved on to parenteral medications. We covered packaging, ampules, vials, injection sites, and recommended volumes, the different types of syringes, standard, tuberculin, and especially those insulin syringes.
And the critical process of reconstituting powdered medication safely and labeling them correctly.
Exactly. Then we tackled the core methods for calculating correct dosages for both oral and parenteral meds, emphasizing unit consistency, that reasonableness check, and appropriate rounding rules for different situations.
We briefly explained percentage and ratio solutions, and then we dedicated significant time to understanding and calculating intravenous flow rates, covering electronic pumps versus gravity, the different types of IV tubing, macro versus micro, and the key formulas for MLHR and GTT-SMN.
And finally, we highlighted the significance of those practice questions at the end of the chapter for really reinforcing all of these concepts and skills.
So the key takeaway for you, our listener, is that a thorough understanding and, frankly, mastery of these calculations is absolutely foundational for safe and effective nursing practice. It really goes far beyond just memorizing formulas, doesn't it?
Oh, definitely. It's about developing the critical thinking and the clinical judgment necessary to ensure the well-being and safety of your patients every single time you administer a medication or manage an IV.
So as you continue your learning journey, maybe always consider the profound impact that accurate medication administration has on patient outcomes. It's huge.
Yeah, maybe ask yourself, what specific strategies will you implement to ensure your ongoing proficiency in this vital skill? How will you practice? How will you double check?
This deep dive has provided, we hope, a solid and comprehensive foundation based directly on Chapter 15 of the Saunders Review. But remember, continuous learning, meticulous attention to every single detail, and a commitment to always double-checking, maybe even triple-checking critical calculations are paramount in this essential aspect of providing high-quality, safe nursing care.
We've covered all the key concepts, the guidelines, the procedures, safety protocols, priority actions, and even touched on those valuable review questions in Chapter 15 of Saunders' Comprehensive Review for the NCLEX-PN examination, a 7th edition. Hopefully this helps solidify it for you.